Welcome. This is a symposium titled Early Diagnosis for Late Diagnosis, Compare and Contrast. I'm Jessica Lamar, and I'm co-moderating with Christine Mavaro, and we're happy that you guys could join us this afternoon on a rainy day here in Seattle. A special thank you to our four speakers who will be speaking today. And then what we're gonna do is have each of their presentations. If we have time for individual Q&A after their presentations, we'll field a couple different questions. But then at the very end, we're gonna have a panel discussion and try to get all your questions answered. So hang tight for that. I'm pleased to welcome our first speaker, Nicole. She's a pediatric program coordinator and interim adult coordinator at Dartmouth Hitchcock in New Hampshire. She has been part of the CF team for 11 years. She was selected to lead roundtables at NACFC in 2019 and 22, and also to present at Nuts and Bolts for the new CF team member in 2024. She's on the Northern New England Cystic Fibrosis Consortium Conference Steering Committee and a board member of the nonprofit New Hampshire CF Patient and Family Advisory Council. Beyond work, Nicole spends time as a professional volleyball mom for her 3 daughters. Please welcome Nicole.
Perfect, thank you. And I had to silence my phone because I was getting texts of plays from the last season volleyball game that I'm missing today. But I am so happy to be here with you. So this is the NACFC presentation disclosure. I have no personal disclosures. This will be my talk, diagnosis mixed bag, newborn to adult and everything in between. Again, no personal disclosures. So Nicole Cystic is my last name. I told her that she had permission not to try to pronounce that. Topics today, newborn diagnosis, CRMS conversion to cystic fibrosis, some adolescent diagnosis in adult. I'm going to touch a little on everything, share some of the things we do at Dartmouth, and some of my own experience with these topics. So first, for newborn diagnosis, we want to start everyone off on the right foot. This is our diagnosis in New Hampshire. So there's only one CF center in the state of New Hampshire, which is at Dartmouth Health, formerly Dartmouth Hitchcock. We had newborn screen introduced in 2006, and we're a relatively small center of 102 pediatric patients. And you can see our diagnosis really varies by year. A big year for us is 5 newborns a year. So I say that and give that context because some of the things we're able to do because we're a smaller center might not work in a large diagnosis center. So our typical diagnosis visit, we're able to get patients in within 1 to 2 days when we get that positive category B newborn screen. Sometimes same day we've been able to see patients just depending on where they were in the state and what the doctor's schedule looked like. So there's always the pulmonologist and then myself. If the nutritionist is available, we don't have access to her every day, but if she is available, she'll come and meet with them, particularly if they need to start on pancreatic enzymes. And we'll talk about the diagnosis, sort of what that means, what typical CF care is. We will do teaching on enzymes if they need those. And we do talk about modulators quite heavily, sort of to give them hope in that first visit if it's applicable for them with their genetics. We do this newborn info packet, which you can see sort of up in the top of the slide. And we'll schedule sweat tests and genetic visits coordinated sort of within the first month of life. So these are just some of the educational things that we give out, our care team pamphlet, just so that they get to know the faces and sort of see who we are, because they will be spending a lot of time with us. We were lucky enough to have a newborn welcome kit put together for us. The original kit was done by a Girl Scout member to get her gold award. So there was a mom of one of our CF patients was the troop leader and suggested this for her. So she spent a lot of time in putting these together. And we really loved this idea of sort of bringing them in, welcoming into the fold with a gift and some information and sort of extra things for them. We attempted to get some funding for a Circle of Care grant, but we were not able to secure that. And sort of we had enough kits and we're a low diagnosis per year state, so we still sort of had enough and said we'll sort of figure it out when the time comes. We were lucky that our patient and family council was sort of reinvigorated back in 2020, and they were really committed to taking on projects to support local families. So they were really excited to sort of take this over for us. So they got input from the team, and they were able to help put together sort of the version 2.0 of the newborn kit. So our kit includes a congratulation card from the care team. I cut that off with my picture, sorry. Letters from parents, adolescents, and adults with CF, and these are members of our centers who we reached out to, and they were, gave sort of their tips and tricks for new diagnosis, shared their hope and what they saw through their life with CF. And then we give sort of, a pill case and a magnet for compass so they have that information, a travel spoon, particularly for those babies that need to take enzymes, and just some little gifts. And then one of our nurses has a cricket, so she very nicely made us onesies that have markings for where to do chest PTs. So we have multiple sizes we can give sort of through the ages too, as the baby grows, to really help parents as they're starting out with chest PT know what to do. And so we really strive for individualized care, which I know everybody does. So I just wanted to kind of compare and contrast a couple different ways we did that. So we had one family that came in, and they were a prenatal diagnosis. They did not do amniocentesis, but the baby had echogenic bowel. They both were carriers, and so we were fairly certain that this baby was going to have CF. It was their first baby, and mom really requested of us, I don't want to look anything up. Please take it slow. I want one topic at a time. If I start to Google anything, I will stress out. So we really took that and took her lead on that and really made sure that we did not overwhelm her. So we started with just enzymes. That baby ended up in the NICU, not for any reason other than the floor nurses were not comfortable giving enzymes on the regular floor for some reason. But so they really we started with nutrition and really just focused on that for a while. And then we introduced chest PT at 3 months, again, just really focusing on that. Didn't introduce nebs until much later, and we really talked about modulators for multiple visits before they were ready to start them, just to make sure mom was comfortable with that. And she is now, I think, she's over 2. I think she's 2.5, and she's on Trikafta and doing beautiful. And actually, this is one of our newer newborns, and this mom was ready to go. So she had a newborn screen that actually just found one mutation, came in for her sweat test, did not sweat. But the nurse on our team who does sweat tests sort of very acutely said, this stool looks like a stool I've never seen before, and I really am concerned. So she started with a fecal elastase right away, had the genetic counselor come in, and we ran full sequencing on her prior to getting the sweat test done. The fecal elastase was our first result that came back, and she was pancreatic insufficient. So even though we didn't have the second mutation at the time, we decided to go ahead and just say, this is going to be CF, we're going to start you on pancreatic enzymes. Mom immediately started researching things. She came in, she wanted, what else can I do? When can I start chest PT? When do the nebulizers start? And she really has been active and wanting to do as much as she can, as quickly as she can. So sometimes we've had to temper her back and go, you're going to overwhelm yourself if you so just take a break. But really is really engaged in care, and the baby's doing beautifully. They're actually in Morocco right now visiting family, so doing well. So the next topic is CRMS to cystic fibrosis conversion. This is just to remind you of diagnostic criteria: an intermediate sweat chloride of between 30 and 59, and 1 or no CF causing mutation. So it really just, if they have this sort of sweat chloride, they end up in there, and then a sweat chloride value under 30 and 2 CFTR mutations, at least one of which does not cause any physical symptoms. So they end up in that sort of bucket category. But approximately 5 to 11% of the children who have this diagnosis will develop clinical features of CF and convert to CF diagnosis. And so, it can happen sort of at any time. And now that we do have that annual sweat test, I think it can sort of pop up and surprise people. So this is just a couple of experiences that we've had in our center. So the first patient had the sweat chlorides were just 33 at 2 months, but then had converted to positive by age 2. At 10 years old, the family actually said, he's fine. He's fine. He can't really have CF. Re-sweat, and actually the sweat was higher at 87. Pancreatic sufficient. does have additional complications of trisomy 21, celiac, and hypothyroidism. So typical CF care was initiated at that diagnosis at 2, and the family did follow quarterly, and they did chest PT, and they had NEBS, but they really disengaged with care around age 12. Mom still wanted annual labs done, but really did not want to come into CF clinic, really didn't want to engage with us. And we had a really sort of hard time kind of reeling her back in and getting her back in. So what it sort of came down to is our refusal to give glucola at one point until she came into a clinic so that we could do the annual labs. And we really have been taking it slowly and step by step to try and re-engage the trust and re-engage them in care. So despite him having a cough, she's still sort of very disinterested, but has agreed to come back to some visits. And has reached out a couple times with antibiotics. So we're working sort of very slowly to regain that trust with them and try to re-engage them in care more regularly. Now that as opposed to patient B whose sweat chlorides, really were close to CF positive early on. And then we re-sweat her at 8 years, and this was prior to the new CRMS guidelines. It really, we reviewed every CRMS patient in our center one year and decided we were going to re-sweat certain people with certain mutations, and she was positive, just sort of out of the blue. Mom was very shocked. The doctor I work with was also very shocked. And she had no clinical symptoms at the time, so she was otherwise very healthy. So she's pancreatic sufficient. We did start her in typical CF care and initiated right at that diagnosis, got her into a CF clinic, and we follow her quarterly. This family is very, very anxious, particularly the mother, and they started journaling everything that this child did. So really started journaling pill swallowing attempts, her moods, her sleep, how she felt about certain things. They engaged with the CF community right away. They started with Make-A-Wish. I went and did a school visit, despite her being relatively healthy. And we were really, really concerned about how anxious Mom was and how much pressure she was putting on this child with sort of the constant and ongoing assessment of every part of her life. And so we had a clinic visit where I asked the child, what gives you the most stress? And she said, pill swallowing and throat cultures. And I said, we can do something about both of those. You don't have to be on Trikafta right now. You're really healthy. And we really had to tell Mom to sort of reel it back. And I sort of chose these two examples of things that happened. I think one is the very disengaged patient and one is the overly engaged patient. And these were both found prior to the new recommendations and guidelines. And in the new guidelines, it says to engage with social work right away and with mental health and screening for parents' anxiety. And it really would have helped a lot in these two cases to sort of know where both families were, because other than that, we were just seeing them once a year. We don't have a really great read on either of them. This particular patient, when we gave the mom the diagnosis, she started sobbing in the room, hugging the child aggressively, continuing to sob, which was really disconcerting for the 8-year-old. And we just had no basis of knowing that that's where Mom was going to come in from. Some social work we don't have unlimited access to, so it's still something we're working on, but really helpful in these cases where they can go for years and years, think their child is fine, and then, in one visit, their child now has the diagnosis of CF. So I will put a plug in for social work for these patients for sure. And then adolescent diagnosis. So it's improbable nowadays, but not impossible. Like I said, we just got newborn screened in New Hampshire in 2006. My first newborn screen baby is 19 in college, so we're getting out of the adolescent range, but we're still there for a few years. We do have missed kids on newborn screen. In 2017, we had 2 misses of homozygous F508. So if it's that easy for sort of a couple of these kids to be missed, it's going to be really easy to miss some with some minimal disease-causing mutations for sure. And there are people that moved to the US that maybe didn't get newborn screened. So those are all things to look out for. And you can see here, this is just a comparison of diagnosis by age, sort of between 2000 and 2010. And although the likelihood is sort of going down that the older ages are going to be diagnosed, it's still not impossible. And you can actually see over 20, it went up a bit, so. And adolescence is a challenging time. So they're looking to be more independent. They've got body image issues. There's peer relationships. There's, social media, which I didn't put in here, but they have a desire to fit in. And where do they fit in the world? And can they be, can they fit with everybody else and look like everybody else? It's mental health, experimentation, academic pressures, sports pressures, you name it, they got it. Now we add CF on top of that. So they've got to learn new routines, new medications. There's all this extra stuff we're asking them to learn about and know about. And now they have this totally changed sense of self. They didn't have CF one day and they came in and now they do have CF. So where do they fit in when they're the one kid that they've known in their entire lives who now have CF? And for some people, this will change their future plans. So that can be sort of difficult to manage. These are just a few examples of patients that we've dealt with in New Hampshire. So this patient A had chronic sinusitis, multiple sinus surgeries, recurrent nasal polyp, sinus cultures positive for Pseudomonas, nocturnal cough, poor weight gain, and watery stools. I think finally had an ENT that sent him for a sweat test and was diagnosed at the age of 13 with sweat chlorides of 84 and 88. Pancreatic sufficient though somehow, even though with the poor weight gain and watery stools. He continued to have poor weight gain too for most of his adolescence. And his goal was really to be a firefighter one day. So, that weight we worked really hard on, because how are you going to carry all that gear, that firefighting gear, if you are barely carrying yourself around? And then we had another patient who had intermittent cough, dyspnea, pneumonia times one, relatively healthy, really was caught by a pediatrician who happened to train under our doctor at UMass Medical Center, who saw clubbing on the digits and went, that's not normal, we should get a sweat test. And we sweat her and she had intermediate values, and the doctor said, it's fine, like you don't have CF, it's probably just CRMS. And then we got the genetics and he went, oh no, she has CF, we need to do something about this. Since then, he's never said, it's fine, you don't have CF to anybody. But she's pancreatic sufficient, and you can sort of imagine that someone was super healthy and her primary symptom was clubbing of her digits, wasn't super engaged in her CF care. And then we have these two patients that actually have very similar ways that they were sent to us by the same ENT, both for nasal polyps with the absence of allergies found. So they both had really primarily those issues, some cough and some patient C was really the most concerning one through psychosocial concerns. She was not picked up for her greasy stools, and she was a chubby baby but poor weight gain. So she was homozygous, and we didn't pick her up until she was 17. So for adolescent diagnosis, get social work involved right away. Counseling for all. We did have psychology in our clinic at one point, super helpful. Goals are motivating. What do you want to do for that patient who wants to be a firefighter? We worked a lot on like the weight gain and what do you want to do? What's going to get you there? And give them space for all the feelings. They might be angry. One of those patients in particular, his dream was to be in the military, and we had to tell them with CF he could not be. And so he was mad, and we let him be mad because that was valid. We took away his dream. So don't be afraid to bargain. That's usually the most helpful when it's the parents giving the bargain. I don't have anything great to give away, but I can stop you from getting your labs this time, but other than that, not really. And don't be afraid when progress hits a roadblock, goes reverse. That's totally normal with all of our adolescents, not just the late diagnosis ones. And then adult onset diagnosis, I say that only because this is the way that we get referrals often. As we know, CF is not adult onset, but for adults now they are. And this is CF is becoming a more common differential now with the increasing ages and survival. Now more adult physicians are looking at that. So the average age of our sweat test at Dartmouth has been increasing over the last few years. So now our average age so far this year is 50 over the age of 3 months. So we're getting more and more adults referred. And we probably have on average about one new diagnosis a year. And they need the same kind of support that the moms do as well. This is new for them as well. So we do have information that we give out to them and, about our care team and about our center. And our awesome PFAC is working on an adult welcome kit. The first iteration of that included a welcome letter, magnet for the CF Center with contact, a CF t-shirt, PFAC information, just kind of like our newborn kit as well. And we do have future plans to add a diagnosis information handout, just like we give to the newborns, that has a little bit more information that they can digest at home, and then letters from adults with CF to sort of share with them as well. And more than anything, we want to give the adults hope. CF doesn't have to slow them down. I think for a lot of them, they've had these symptoms and they didn't know why, and CF was sort of the missing piece of the puzzle. So we want to give them hope, like, we know the reason now, so we can help you get better. And what the burden is how do we help you fit this into your life now that you have this new diagnosis, new routine, and new medications that you need to take? So that's really where we come in as a care team, helping them reach their goals, letting them know research is ongoing, and we are always here for you. We're just a My Chart or a phone call away. And with that, I've got my little Oscar speech here to thank I want to thank the children, adolescents, adults, and families with CF for entrusting us with your care and allowing us into your world. PPAC for sharing your valuable perspectives and acting as a bridge between people with CF and the care team, and the pediatric and adult care teams at Dartmouth Health for their compassion and unwavering dedication to our patients and our team. Thank you. Do you want this one? This one's on.
If anyone has questions, could they come to the microphone? I do have one.
Should stand here.
And not to put you on the spot, Nicole, this is out of my curiosity. This is, I think, especially for like more your adolescent or adult diagnoses, but how does your team provide emotional or spiritual support to patients and their families during their like diagnosis visit? I've just encountered a couple newer adult diagnoses, and I feel like that's the challenging, like a lot of the challenging part for me.
Yeah, I think what we try to do is meet with the family and see sort of where they're coming in with. And we've had some families that sort of take it very well because, like I said, they felt sick, they knew something was wrong. So at the time of it, they're doing well. Like the patient who was very angry, he was very angry at his parents and because he said, I told you that I couldn't run, and he was really mad. And so we tried the best that we could to support him, really talked about counseling. We talk about therapy for everybody. Nobody really does that, but we really try to push that. And when we had the psychologist, she was available to either meet with them depending on when they were coming in the office at the same time, or we could set them up with a telehealth to try to do that. And it's really getting either social work involved or sometimes child life, depending on for that CRMS diagnosis. We really wish we had child life involved. Just sort of helping support them through that diagnosis visit, and then making sure they're leaving with some more supports and services, and so they know they're not alone.
Thank you so much. That was great. Marcy Sontag, Center for Public Health Innovation. I was wondering about especially your adolescent diagnoses. Do you know race and ethnicity on those kids, and might that have played a factor into them having
What was the first part of the question? I'm sorry, I didn't hear it.
In your adolescent diagnoses for race and ethnicity, do you know what their race and ethnicity was, and if that played a factor? Because sometimes we see that, oh, your child's Black, they can't have CF or whatever. And I was wondering if that played a factor in any of those.
We're a very, very white population in New Hampshire. Actually, all 4 of those diagnoses were white. Yeah. And one of them, the brother was born in Massachusetts that had a newborn screen at the time of his birth, and then the family moved to New Hampshire, and we didn't have a newborn screen yet, and that's how she was missed. Yeah.
Thank you.
Thank you. Thank you.
Next, I'd like to introduce Max. Max is a physician assistant in the pediatric CF clinic at Primary Children's Hospital in Salt Lake City, Utah. A recent graduate of the LEAP Fellowship through the CFF, Max is passionate about clinical care of people with CF. He has led multiple QI projects at his center and is a member of their transition committee. In his free time, Max likes to ski, cook, and read. Please welcome Max.
Thank you, everybody. I'm going to be talking about a teenage CF diagnosis and looking at some of the challenges and successes with this particular case, and then looking at key takeaways from how we care for newborn diagnoses that can help us be successful in a later diagnosis. So I have no disclosures related to this presentation. In the theme of the symposium, we're going to be comparing and contrasting newborn diagnosis versus this case. And this case is shared with the permission of the patient, who's now an adult. DJ, at time of diagnosis, is a 17-year-old male who is diagnosed by dermatology with aquagenic wrinkling. And because of this, the dermatologist ordered a sweat test, which came back positive at 63 and 61 millimoles per liter. And they placed a referral to our pediatric cystic fibrosis clinic. Of note for this case, newborn screening in Utah was instituted in 2009, which was 3 years after DJ was born. So at our first visit, I obtained a past medical history from DJ and his parents, which was positive for suprasellar arachnoid cyst, status post-decompression via endoscopic fenestration at age 14, and short stature with advanced bone age that was believed to be secondary to this cyst. His parents deny any past pulmonary history, sinus history, gastrointestinal history, or nutritional concerns. And there was a lot of anxiety and denial from DJ's parents about the possibility that DJ could have CF, in particular because when I was asking them questions, about pulmonary history, everything I mentioned before, they were adamant he had never been sick and never had anything indicative of CF. So thinking about this first visit versus a standard newborn visit at our center. Some of the similarities is there was parental denial, which I want to give the caveat of that's not always the case, but certainly can be seen at any new diagnosis. And I think that one of the confounding things for the family, as it is for a lot of families, was there's no family history of CF, and it feels like it's come out of left field. Very emotional visit for the parents, in particular a lot of anxiety and fear, which again, very understandable. No one wants their child to receive a chronic, lifelong, life-limiting diagnosis. And we ordered CFTR testing and a fecal elastase. Again, kind of with the caveat that sometimes at a newborn diagnosis, we already have 2 CFTR variants identified, but we often do need to order further genetic testing, and in this case, we had no genetic results at this point. Key differences. We have an older patient with reported lack in signs and symptoms of CF, which, as I already mentioned, made this even more confusing for his parents. As I just mentioned, we didn't have any genetics to help further confirm this diagnosis and as another data point for the parents. And not only are we educating the parents and family about CF at this visit, but also educating the patient, which definitely is different than when you have a newborn diagnosis. At this visit specifically, we provide some center-specific education while we were in clinic and recommended that the parents review cff.org for more information while we were awaiting the results of our testing. So at our next follow-up, we had the results showing that DJ does in fact have cystic fibrosis and has 2 CFTR variants. He's heterozygous for F delta 508 and a 12TG to 5T. He also has mild to moderate pancreatic insufficiency with a fecal elastase level of 160. We got first PFTs at this next visit, which show very healthy lung function with a percent predicted FVC of 124 and percent predicted FEV1 of 122. And so at this visit, we went into further in-depth CF education for DJ and his parents, trying to really explain the diagnosis, why we were confident in the diagnosis and all the testing we had done, and then engage in some joint decision-making regarding the treatment plan. DJ's dad has a background professionally in medicine and had done a lot of research about CF in between visits and had a lot of ideas and opinions about how DJ's care should be enacted moving forward. And so the initial plan at this visit ended up being that we were going to start elexacaftor, tezacaftor, ivacaftor. We did go over all available treatment modalities for DJ and had conversations about the pros and cons of various treatments we could start for him. And his parents were adamant that what they wanted was to start him on ETI given the research that they had found online. We additionally started pancreatic enzyme replacement therapy, given his pancreatic insufficiency, and went over extensive education regarding CF pathophysiology, infection prevention measures, and the treatments that we had discussed. And based on our conversations in that visit and seeing how difficult this was for the parents, we decided to have a sooner than routine follow-up so that we could support DJ and his family during this transition in this diagnosis. So now we've had a couple of visits and we're initiating treatment. Some of our big similarities between this and a newborn diagnosis are we're going over a lot of education. This is a lot of information for a family to take in about CF, how it affects the body, talk about infection prevention, ways that, DJ or parents of a newborn will have to kind of change habits and lifestyle and ways to keep them healthy. We talked about discussing treatments and planned on slowly ramping up therapies to not overwhelm the family. And then engaging in frequent follow-up and support, for emotional support, trust building with the family and patient, and also education. Big differences. Again, we're educating the patient. I feel like this bears repeating as, a lot of the times when we have a newborn diagnosis, that child's going to grow up learning a lot of this over time. And this is such a big change for DJ and so many new things for him to learn. And in particular to that are considerations for adult life that he suddenly has to be met with. Thinking about what he can do for higher education, where he might need to go to school to have access to CF care, careers that maybe would be inaccessible to him now due to infection prevention guidelines, and then his desire to serve a religious mission and some of the limitations that having CF are going to place on that for him. His initial treatment is ETI. That's not standard for a newborn. Now we're often able to start patients eligible for ivacaftor very young, but having his very first treatment for his CFB ETI felt very different to me than what I had experienced before. And really just what a drastic change this is for DJ and his parents, given the fact that he has no prior health history that would be indicative of CF. His parents brought this up at every visit for the first few visits we have of this doesn't make sense. He doesn't have lung problems. He's never been sick. He's never been hospitalized other than his surgery, and really just how confounding that was for them despite the evidence of his diagnosis. So at our next follow-up, DJ reports that he's been taking his ETI consistently and having no side effects with use. But since starting PERT, he has been experiencing near daily abdominal pain, even though he does report his stools have normalized and he actually feels more full more quickly than he used to when he eats meals. So after going through our visit, our plan at this point was we went over education about high-frequency chest wall oscillation and prescribed him a vest, really just for him to have one for if and when he starts experiencing pulmonary exacerbations and to start getting him used to the idea of having one. And I wanted him to practice performing some airway clearance with the goal of building up to once daily by his next follow-up. Explain to him and his parents, I'm not necessarily saying I want you to do this every day forever, but I wanted him to become familiar with this so he could come back, talk to our respiratory therapists, ask questions, make sure he understood how to use it if and when he needs to use it in the future. We decided to repeat a fecal elastase. At our center, and I think there's data from other centers nationally, that some pediatric patients who are taking highly effective modulator therapy who have pancreatic insufficiency are having an increase in their pancreatic function, and some of them are becoming pancreatic sufficient and decreasing the amount of pancreatic insulin replacement therapy that they're using. And we felt that this was a particular enough case that we wanted to see if that was what was happening to him. We continued his liver function monitoring and planned for a 3-month follow-up at this point. So his fecal elastase came back at 641, showing pancreatic sufficiency. I called DJ and his parents to discuss this over the phone, and we decided to have him continue PERT with his ETI and associated high-fat food, but otherwise discontinue and see if this would improve his abdominal pain. And I let him know we'd reassess over the phone in the coming months, and we'd plan on a repeat fecal elastase in 6 months from then. So now we've had multiple visits, we've initiated DJ on treatment, and thinking about how this compares to a newborn visit. Very similarly to our newborn diagnoses, we're having continued education about CF. As I think most people in this room probably well know, this is not something you can learn in a day or even over a couple of visits. There are so many nuances to CF, the science, the pathophysiology, and the care that takes a lot of time to learn. Lots of questions from parents about prognosis, treatments, and outcomes. Again, very understandable. I think we would all want to know those things for our children. And this was something that came up as a recurring theme throughout our visits, which I think is fair to say happens with a lot of CF diagnoses. And then difficulty adjusting to the diagnosis. And I put that in the similarities because this was for the parents. DJ actually has done very well adjusting to his diagnosis, but his parents are having continued struggles accepting his diagnosis and dealing with this new reality. One of the major differences is that DJ understands his diagnosis and treatments better than his parents. which in a lot of ways is astonishing for me because most of our pediatric patients, like I said, have grown up with this. They've been taught this by their parents. Their parents have had to be the stewards of their health. But DJ has been the one to take hold of the reins and say, I want to understand this and I want to take care of myself. And I think in some ways he had to, given the difficulties his parents had following the diagnosis. His rapid conversion from pancreatic insufficiency to sufficiency after starting treatment with ETI is very out of the ordinary for a lot of what we see. I don't think it's impossible to see that in younger children, but typically we have children starting modulators a little bit younger and then we check their fecal elastase later if we are. We never provided education for chest physical therapy, went directly to vest therapy, and he's already performing PFTs. So we have that as another data point that we can use in his care and his plans. So where are we now? After a year and a half, DJ's doing really well. He's never been hospitalized related to his CF. He has infrequent oral antibiotic use. He's not chronically colonized with any bacteria, and he's independent with his treatment and care management. I think some of the big successes in his particular case are his independence with self-care, and he gets all of the credit for that. He is a very remarkable young man. Like I said, he has taken this in stride, and I think it's helped him feel a sense of power and ownership over his diagnosis to say, I'm going to take care of myself and I'm going to understand this. And because of that, he has a very high adherence rate. I think he's seen that he does feel better if he's doing his treatments. He's now had a few very mild pulmonary exacerbations where utilizing his vest and utilizing inhaled therapies, he gets better without needing oral antibiotics. And he's kind of seen, oh, wow, this does help me get better faster. And it helps me, feel better while I'm sick as well. His understanding of his disease process is really well. I think he's done a great job engaging with the educational tools we've given him, doing some research on his own and trying to better understand this so he can take care of himself. And he has a really positive outlook about his diagnosis. I don't know if that's just his intrinsic nature or if it's because he hasn't had a lot of major health challenges associated with his CF up to this point, but he's doing really well and has a positive attitude every time we see him in clinic. A lot of the challenges more related to DJ himself during this diagnosis and transition, learning the nuances of CF care. As I already mentioned, this is a complex disease that's hard to learn and hard to learn how to take care of. Some examples are DJ having to learn how to increase his airway clearance therapies when he is sick and when to start those increased therapies. Having to use Miralax and perform bowel cleanouts. Some of his biggest CF symptoms so far have actually been GI related and experiencing more constipation and having to perform bowel cleanouts. And then when to communicate with the care team and how to do that. Like I said, he's really had to take charge of his own care. And really from the time he was diagnosed, he was the one calling in and asking questions or saying, I'm not feeling well. But there definitely was a learning curve for him when he was trying to figure out how to do that. A lot of anxiety surrounding changes from baseline, and this is more on the part of his parents. There was a lot of difficulty during his first pulmonary exacerbation that required oral antibiotics. His parents in particular seemed to think that it portended a permanent negative change in his health status. And even after he was better and his PFTs improved back to baseline, I think his parents still were very concerned that this was a harbinger of something worse for his health. And as I've gone over multiple times now, the acceptance of his diagnosis for his parents. We are finally there. I think they clearly went through the 5 stages of grief related to his diagnosis and his health, but that was a very difficult road for all of us to kind of navigate together. So big lessons from early diagnosis that I think made this case and can make later diagnoses successful. Frequent education, check-ins, and support early on. We see newborn diagnoses every month for the first month of life, for the first 6 months of life. And that's for a variety of reasons. But I think in a case such as this, it was really helpful to meet with DJ and his family multiple times over the course of a few months to not overwhelm them, to help build trust between them and the care team, and to help them feel supported in that moment. And I think it also can help increase the likelihood of successful treatment implementation for these patients and families. Ramping up of care and treatment education. I think, where appropriate is the caveat I'm going to give this. Certainly if someone is having signs and symptoms of CF, is frequently hospitalized, needs to start treatment modalities and therapies sooner, then we need to put their health first and foremost. But where we can, I think if we don't throw the kitchen sink at someone and can let them adjust to new therapies, to their new diagnosis, and ramp up their care as appropriate, that will also help improve treatment adherence and their acceptance of all of these new changes. And then, very importantly, as I've tried to touch on multiple times throughout this presentation, validating feelings and utilizing resources as appropriate for the patient and family. I'm going to give a plug for the Partnership Enhancement Program. Those skills were invaluable when trying to help DJ's parents process their emotions related to his diagnosis, have these difficult conversations, especially where they were very much either flat out denying or questioning the diagnosis and trying to work through a lot of that with them. I would not have been able to do it without these PEP skills, and I was very grateful for that. Early access to your center or our center's mental health team as appropriate. I did recommend these resources to DJ and his parents. None of them wanted to take advantage of that. As I said, DJ overall seems to have done very well and has a good attitude about his diagnosis, but I did feel it would still be helpful to try to engage with those resources. He didn't feel the need for that, and his parents felt that they would rather search for those resources, on their own outside of clinic. And then CFF Peer Connect, I think, can be a fantastic resource. DJ and his parents did not engage with that, but I've seen that be very beneficial for a lot of our families following a newborn diagnosis, and in that case, for the parents to have someone else to talk to and go over those feelings with someone who understands it in a different way than the CF care team. And then some key considerations in late diagnosis that I think are important to mention are understanding what an adjustment for the patient and family this will be regarding future plans and expectations. A key example from this case is in Utah, there is a culture surrounding family planning and having large families, and DJ is a member of this culture. And when I first met him, one of the questions his dad did bring up after doing his own research was, hey, I found this thing online about the absence of the vas deferens. Can we talk about that? And so then we had to have conversations about, DJ can still father children, but it will most likely require IVF. And that's, a very large change compared to the future he had most likely envisioned for himself when it came to something like family planning. And then I think there is potential for increased confusion and or denial, as we've seen in this case. As I mentioned, I think if you have a patient who arrives very sick, who has a lot of pulmonary infections or a past pulmonary history, and it aligns for the parents, I would think in that case, hopefully it would be a little bit more easy to accept or at least make more sense. But in a case such as this, that was one of the big sticking points, that it didn't seem to align for parents and how they viewed DJ's health, and it really made it a lot more difficult, and it took a lot of care and consideration in navigating those conversations. I am so sorry. To try to work through those. And then I think, thank you, where appropriate, utilizing joint decision-making in your approach to the care plan, I think can be really helpful. That I did feel was one of the biggest victories we had with DJ's parents. I think they felt very heard in, us discussing the care plan, their wishes being taken into account, even though maybe at that moment, did he need ETI based on symptoms and presentation? No, but his parents were very anxious about what his future would be like with CF, and I think that by being able to start ETI, it helped mitigate some of those fears for them, feeling that he was getting the top of the line treatment and one of the newest therapies available to CF patients. But thank you all very much, and I'd love to take your questions.
I have one question. The question is, do you have a hard time getting them coming in once a month for the first 6 months at your clinic?
For newborns or in a case like this?
For newborns.
Not typically. I would say most of our newborn diagnoses, the families are very willing to come in once a month for the first 6 months. Every once in a while, there is a one-off where either they're not as accepting of the diagnosis or having a hard time with that acceptance and maybe don't want to come in due to some denial, or we serve a very large geographic area. So we definitely run into some instances where families say, the distance and cost of this are very hard on us, and can we try to do something else? But for the most part, we have a very high acceptance, or not acceptance rate, sorry, a very high adherence rate to that frequency.
Any other questions from the audience? I have one for you, Max, otherwise. I know you brought up family planning and like male fertility. And I guess I just wanted to logistically ask about what you usually do when you're talking about that, and do you refer them immediately for like semen analysis or to see urologist fertility, how that works in your clinic?
Yeah, that's a great question. We did a quality improvement project a couple years ago about providing CF reproductive health education to our adolescent patients. So for patients who are already diagnosed, we have a structure where we provide age-appropriate education starting at age 15 over time to go over those things. We offer either in-person discussion with a medical provider, or we have handouts for them. They're also free to defer or decline that education. When we've talked to pediatric urology at our institution, they've told us they don't want us referring to them, and that that's an adult issue they can deal with when they go to the adult care.
I just have a question that's kind of weird, so I apologize to everyone for this. But you said he had short stature. So with Schwartzman-Diamond syndrome, do you ever look at that when they have a negative, like if they don't have a positive sweat test? Like, do you look at that route since they are very similar diseases?
I haven't run into that. Like in this case, he had a positive sweat, and then we found the CF genetics, and so that didn't come up. And typically, we're only getting referrals if they have an intermediate or positive sweat, and then oftentimes, if it's intermediate, we'll ask the family to get genetics before we see them, and if it's positive, then we'll see them in clinic and get genetics. But that's not a scenario I've run across personally.
Okay. Yeah, I was just curious because it's interesting because my son has CF and I have a niece who has Schwartzman syndrome. So it was just a question I had. Thank you.
Yeah.
So I have the pleasure of welcoming Jennifer Stewart. Jen is a nurse practitioner with the Pediatric Cystic Fibrosis Center in Salt Lake City, Utah. She worked with the CF population for over 19 years, initially as a nurse in the hospital and now as an NP providing both inpatient and outpatient CF care. She enjoys caring for patients and families with CF and is passionate about quality improvement and education. She loves adventure and traveling with on her time off.
Thank you. All right. Thank you guys so much. I am excited to be here and present on a topic that I'm very passionate about, and that is navigating a new diagnosis, specifically within that first year of life. I'm not a parent, but I can imagine that having a new baby that first year of life is difficult regardless of a chronic illness. But you add CF to that, and I think it just adds a whole different complexity and another degree of challenges. I don't have anything to disclose related to this presentation. First, just wanted to talk about a little bit of background. The first CF diagnosis was way back in 1938, and thankfully we've made a lot of progress since then. Newborn screening started in the 1980s, took several decades to fully be implemented, but by 2010, all 50 states were using the newborn screen. Utah was unfortunately second to last in 2009, but we made it. We are a two-screen state, so we use IRT, and then DNA as our process to detect babies with cystic fibrosis. Of course, our goal with the newborn screen is to diagnose and then to be able to treat as early as possible. And this, as we all know, has significantly improved outcomes and quality of life for people with cystic fibrosis. Our goal is always as short as possible, but currently our average number of days at our center is 20.6 to DNA diagnosis. We are a large center. We see more than 300 patients in total, and as Max mentioned, we do have a large geographic area. We typically see about 15 to 20 new diagnoses a year. So this is a significant population. And most of these babies are diagnosed through newborn screen. So we know this is a very difficult time for families. There's a lot of positives to being diagnosed as early as possible, but I think the hard side of that for families is that their baby is typically very healthy. They often don't have a family history of CF, and this is coming out of left field and is just a complete shock to them. So we know this is a very difficult time for families to receive this diagnosis. They're also receiving it at a time when they're tired and adjusting to a new baby in their home. So lots of things going on. So we at our center developed a subgroup for quality improvement several years ago to improve processes and increase support for these families. And I do want to share lots of these things that we're doing in hopes that it may help some other centers with different ideas, but know that these have been in process for a long time too. I recognize they're not easy for everyone to implement right away. So our quality improvement group was made up of several CF team members of different disciplines, and then we also had parent partners, which provided a very valuable perspective. This specific group started in 2021, and we would meet virtually monthly. The goals really were to improve processes surrounding diagnosis and CF care within the first year of life. We kind of focused on three main topics, being support. We wanted to increase the support that we provide to families. Education, we really wanted to look at the education we're providing and improve where we could. And then also standardization. Our center has multiple providers within each discipline, and we wanted to ensure that whatever provider you were seeing that day gave the same information essentially, and that everyone was receiving similar type of care. Several projects that we had in mind initially were based on parent feedback. We had several parents who had said they wish they would have known, like looking to the future, what was coming within that first year. So we focused a lot of our efforts on developing a timeline, both for staff members and then also for families to get in their newborn kit. And I'll show you an example of that. We recognize, though, that everyone has a different, everyone wants kind of a different, potentially, picture for this. Some families, I think, are so overwhelmed and don't want to know that timeline of all these things coming next. And others feel like that's really helpful to know what is coming looking ahead. So we provide it, but know that not everyone is going to want that. We also worked closely with our newborn screen program to improve communications. That's been another big part of our project. We've increased communication with the newborn screen team, who then also communicates with the pediatricians. And then we wanted to be sure the pediatricians were giving clear information to the families. So I wanted to share some quotes from families at our center. I think this helps provide a really good perspective on what people are going through when they're first diagnosed. And then I also want us as clinicians to recognize the importance of the work that we do and the lasting effects that we can have. So one parent said, finding out that you have a child with CF is terribly traumatic and isolating. We'd heard of the disease before, but truly did not know what it meant. My husband and I were shell-shocked and would not have been able to sort out what we needed to go out and get immediately to care for our child if it hadn't been for the clinic. Not only were we navigating being new parents, but now we're learning an entirely new language and thrown into a world we never knew existed. Sometimes it felt insurmountable and the future seemed so uncertain. We felt so overwhelmed and had to sketch it all out on a whiteboard to see how it all fit in a day. The CF team has supported my daughter and our family from the day we first met them. It made a world of difference to us to feel like we were not alone in this new journey. Our CF clinic was like a hand reaching out in the dark to guide us every step of the way. We've always felt so grateful that our clinic seems to go above and beyond to support families, follow expert care guidelines, and keep up with the latest research. So I think it's really important, especially within that first year, to be sure that we're giving patients and families all of the support and education that they need to be able to cope with this new diagnosis. We are very lucky to have a strong parent advisory council, who many of the members are here today. Thank you. And they do an amazing job collaborating with us to provide feedback, come up with new ideas, make sure that we're providing optimal support. So they've really helped us kind of ramp up our newborn kids. We also now provide infant scales for all of our new diagnoses so that we can help monitor weights at home in between clinic visits. We've also focused on relationship building and education with the provider that the new baby is seeing. We have a pharmacy call after the visit and make sure that the patient is enrolled with access programs, has active insurance, kind of helps the family work through all those initial difficulties. Another thing we've implemented that's been really helpful is that the nurse will call the family a week after their first appointment. And we found that this has been really helpful because we know that first visit is hard. It's long. They're meeting a lot of new people. They're tired. It's shocking. It's like a fire hose of information coming at them. And we know they're not able to absorb everything. And yet we're giving them a lot of really important information. So to reiterate that information and help them hear it more than once, we have the nurse call, and they have a template that they go through, making sure to review key topic items. And it also provides an opportunity for them to ask questions that they've thought of in between the visit. We now also have a nurse on our team who's a breastfeeding consultant, so that's also been really helpful for new babies. And we are very lucky to have a feeding therapist as part of our team. We now have combined CF feeding clinics where the babies can come and the family can see the regular CF team in addition to a feeding therapist, and that's been super helpful. And then most recently, we worked on this for a long time, but we now have a genetic counselor as part of our CF team. And that's been really huge and awesome for our team and for families, certainly new diagnoses. So just some pictures of our newborn bag. We actually have split up our newborn bags. So the first bag is given at the first visit where the focus is generally more nutrition and growth focused. The second bag, which I will also show you, is more of a respiratory focus. So there's pictures of things in this bag. We start enzymes, vitamins, salt. But what's really cool, I think, about this bag is that we give a newborn book that was designed with our clinic and the Parents Advisory Council. And there's lots of words of encouragement from parents who have lived the CF experience. And it's also really cool. There's pictures of patients and parents have both consented, of kids with CF at different age timelines, who are living their best lives, who are thriving. And I think that's really helpful for parents of new babies with this diagnosis to see. Just another quote from a parent. She said, "The newborn kit was such a nice touch. One of the most memorable things to me was receiving an insert written by fellow and local CF moms. It's great to connect with other parents who just get it and can also reassure me that things will be okay. A medical professional can provide reassurance, but it hits different from a fellow parent." So I think that's an important point. These are just some of the pictures of the information that's in that book. There's a Welcome to Holland letter, if you're familiar with that, and the 65 Roses letter. And then we have some fact sheets, kind of do's and don'ts, and commonly asked questions. This is the timeline that I referred to earlier, what to expect in the first year of life. And you can see it's a lot, we know that. But this was designed based on CF guidelines, AAP guidelines, and then also some of our just clinic discretion. Because a lot of parents had questions about, what do I go to my PCP for? What do I see you guys for? We know we're seeing them frequently, monthly in those first 6 months, and then every 2 months for the first year. So lots of appointments. And we're generally starting something new or teaching something new at each appointment. So a lot of the families reported that this was helpful for them to kind of know what was coming next. And then also to have it align with their pediatrician visits and vaccines and things like that. One thing I wanted to point out on here is that we do try to get all of our babies between the ages of 3 and 6 months scheduled in a CF feeding clinic to help assess feeding patterns. And then as they're starting to start solids, the feeding therapist can provide some really good information there. And we always give the caveat too that of course we provide individualized care. This is a rough guideline. It's not an exact expectation. We definitely base this on the family's comfort level as well as the clinical status of the baby. This is the second bag, which is more respiratory focused. And similar to our first presenter, we also have the onesies that help with the CPT placement. One thing that I wanted to share here that I think is unique or new is that we have started providing a baby bottle sterilizer to families with the help of the PAC support. We've just done that in the last couple of years, and there is a poster, I'll put my poster plug on there, there's a poster about this. We've seen multiple benefits from that, one being that it reduces the burden of care for the new parents. We know that there's not a lot of time in the day when you're feeding and doing treatments and meds and all of these other things. So that helps reduce the burden of care. But then it also, we think it helps reduce infection risk. And that poster does show that since we've implemented this, we've been able to reduce Pseudomonas aeruginosa infection rates in these babies. Just some more pictures of the respiratory book. I think one thing that's really helpful is that there's these QR codes that take you to instructions of how to clean and disinfect the equipment. Another topic is improving our education. So just wanted to kind of quickly share some of the education that we provide. We give everyone this book. Wanted to make sure everyone was aware of this Introduction to CF. You can order these free from the CF Foundation for your clinic through MyCFF, through the resources page. So I think that's a really good book to provide families. We always give that to them with this first kit. And then we also give them information about supportive resources like the PAC, parent mentors. We always refer to cff.org for Googling rather than Google. And then different handouts that are given kind of throughout the timeline. First visit education is largely with the provider. We think that that's really important for the provider to spend the most time in there, building trust and going over a lot of this information. We don't always have everyone on the team see the family at the first visit, generally the provider, and then dietitian and the pharmacist. I'll kind of skip over this because I think I'm running out of time. I talked a little bit about the nurse call a week after, and I think that that's been really helpful. During that call, they also make sure that the patient has a follow-up appointment scheduled and then that they have access to the health portal. So standardization that I briefly mentioned a little bit about, we think this is really important because we have 4 different providers at our center and we all share patients. The new diagnoses are generally seen by whichever provider is available as quickly as we can get them in. We want to make sure that we all are providing the same information and addressing things in a similar way. So we try to have at least the first and second visit scheduled with the same provider. We also have 2 dietitians, 2 pharmacists, 2 social workers. So we've come up with a timeline that all of our staff can see so that they know what's expected at each visit. I mentioned a little bit about our genetic counselor, who we love and are so thankful for. She is 0.4 of an FTE, so 16 of her hours a month are dedicated to CF. We generally have her either come in person to the second visit, or if she's not able to come that visit, or if the family prefers, they can see her virtually. We decided not to have her come the first visit just because it is so overwhelming, and they do get the basic genetic counseling initially through our health department newborn screen program. But she can talk about a lot of different things, especially if they're difficult or unknown variants. She does discuss CFTR modulators, and then kind of looks at the whole family and talks about sweat chloride testing for siblings as well. I mentioned a little bit about our feeding therapy clinic. We hold these twice a month, and they have been really, really great. As you can see, we have developed handouts there too, especially for babies starting solids. We know that nutrition is important in babies with CF, all babies, but especially babies with CF, and that they can often have feeding problems. So the feeding therapist has been monumental. One of the parents said the feeding clinic was vital to us in that first year. We dealt with so many feeding issues, and it was our greatest struggle. The stress multiplies then when you were concerned about getting your baby in adequate calories for CF standards. So really a helpful support and tool there. This is just graphs showing the improvement in access since we've started those CF feeding clinics. Previously, we would refer out, and a lot of times those referrals were never even scheduled or seen, and this way it kind of combines appointments, and it's also not an extra cost to the family. So that's been really helpful. So these are just some other pictures of things that we provide. So a pamphlet with our clinic information, all of our team names and pictures. We also give the information for Compass and some CF resources. We make sure that they know how to reach us and know that there is no silly questions, so they can ask anything anytime they want. Another quote, I've always found great comfort and support by being able to message clinic staff easily. So through a lot of these things that we've been able to implement, we really have been able to help newborns with CF thrive. We're able to give hope to parents and families. Really important to build trust in that time frame. And then ultimately our goal is to improve outcomes, especially because we know that time is so crucial to kind of set the stage for the rest of their lives. Just real quickly, some additional efforts, because we do have babies diagnosed in the NICU at times. For some reason, this last year has been more frequently than ever before, but we have put some efforts into improving care in the NICU as well. We've developed guidelines for our NICU team so that they kind of know our standard processes. We're able to get a clear diagnosis, and then we make sure that they consult us in a timely fashion as well. We've set up weekly rounds where our team will actually go over to the hospital, meet with the inpatient team, and then we invite the parents to come too. So it's really at least once a week, make sure that we all connect and communicate. We have designed worksheets that are laminated and hung at the bedside with CPT reminders. Not all of the RTs see CF very often, especially in the NICU. And so we had lots of feedback from parents that there were inconsistencies, and we want that to be as consistent and as effective as possible. So those reference sheets have been really helpful to have at the bedside. And then when there is a new diagnosis, we often will schedule a block of time in a conference room and let the parents invite family members or support whoever else they want to be there. And then several members of our team will go over and spend the time to talk about the diagnosis, educate on CF, and give them an opportunity to ask questions. Other things that we've done, as I kind of briefly mentioned, is work with our newborn screen team to help improve processes. We meet with them in person, which has been helpful to get to know the people that we're emailing. We've designed a letter that goes to the pediatricians that has clear and concise information about what this newborn screen means, what the results mean. We had too many instances where the family was scheduled with us being told the baby most likely didn't have CF when we had mutations or, things like that. So that's been helpful to give clear information. And then just a side note, we did recently apply for the SIP grant, which we're hopeful for to expand our newborn screen panel. And lastly, just to wrap up, I think parents often say it best, but this quote helps to provide that perspective. And then I think also just gives us a good reminder of the impact that we can have and the importance of our job and efforts. So I will finish with this. I'll never forget sitting in that room surrounded by a group of professionals who I could already sense truly cared for our newborn daughter. They offered us education, resources of support for our family, answered our many questions, and offered hope. It was an immediately comforting feeling to know that while our daughter had this disease, she was going to have an amazing team of professionals watching over her health and supporting our family. We were not alone. With that, I'm happy to take any questions.
I have one question. Who pays for the bags in your clinic?
Pays for the what? The bags. Yeah, it's a great question. So it's a combination of Parent Advisory Council funds, and then we also have requested certain things through our institutional foundation with grants that can be dedicated to CF. So a combination of things. We try to buy in bulk so we get lots for a year or two. And then if there are things that we want to add, then we talk with our PAC and budget and see what we can add.
And one more question. What's the turnaround time from when you get a positive newborn screen until they get their sweat test appointment?
Yeah, good question. So our newborn screen only runs genetics once a week. So Tuesday afternoons is when we're always kind of expecting to hear back on those screens. If it's two pathogenic mutations and high IRTs and highly suspicious of CF, then we get them just seen in clinic pretty automatically in the next 1 to 2 days. If it's an unclear diagnosis, then the newborn screen actually helps schedule the sweat, and usually it's within the week. Mm-hmm.
Hi, I have a question about your newborn kits. I love that you separate them in, 1 and 2 in the respiratory, but what do you use the honey bear bottles for? I saw the MD bear bottles.
Yeah, great question. Sorry I didn't have a chance to expand on that much. So the honey bear bottles were an idea from our feeding therapist, and they're given around that 6-month age mark with instructions for use and cleaning, just to help babies start to use a straw. So it's kind of an advancement as they're developing their oral skills. Okay, thanks.
Next, I'd like to introduce Jana Yelly. Jana has been working in the CF world for over 30 years and as a nurse practitioner with the Indiana University Adult Cystic Fibrosis Center for almost 25 years. She has presented and moderated at NACFC over the years, been involved with the LEAP program and other previous mentoring programs. She is the coordinator for the CF Center and a provider, sharing over 350 patients and with 3 physicians. Outside of work, she loves her puppies, reading, and spending time with her family and traveling.
Thank you for allowing me to present this patient. I'm I'm going to do things a little different because I'm actually going to present an adult patient and diagnosing her at her late age. A lot of the previous speakers have covered, I think, newborn diagnoses and a little late diagnoses pretty well, but this will also show you kind of, it's different, but it's a lot of the same as well. We usually have with our center about 3 to 5 new adult diagnoses a year. Obviously, we evaluate several others that are just ruled out of CF. And then they are very individualized too. Some patients come to us with reproductive issues, especially the males. Some come to us with just GI issues. Some come to us with pulmonary issues. Others come to us with a combination of those. So therefore, it's a variation of what we see and the reason why they've actually been sent to us from an outside provider. So it's titled A Little Late, but Look at Me Now. I have no disclosures. And then the later diagnoses of cystic fibrosis. So presentation, this is the records that basically I receive in order to evaluate whether or not this, do we need further testing before this patient comes to see us or not. So she is 41 years old. She's married, and she was also working as a full-time RN. So she does have some medical background. She actually saw a local pulmonologist, was a different pulmonologist than what she's seen throughout her years. And the moment he saw her, he decided to go ahead and run genetics. And so she came back with homozygous F508, which I know is very strange for someone to have those two mutations and be so much older in life and with a diagnosis. But what was happening was that she was diagnosed with COPD, which, as you know, sometimes in the adult world, some of our patients come to us having diagnosis of asthma or COPD or some other pulmonary diagnosis, and then we always change the diagnosis to CF whenever it's positive. She also had, in 2020, she had an abnormal pancreas, and so therefore, on a scan, and so therefore that was the other clue to him that he needed to test for cystic fibrosis. The benefit of this is she is from an area where there's actually the pediatric center, CF center, that is down there in their area. So some of the pulmonologists down there are a little more familiar with CF actually, so that's probably what prompted him to send him. They never completed a sweat chloride because they had the genetics, so we went there. But signs and symptoms that were prompting her visits, the particular visit to send us here to us was the dyspnea on exertion with minimal effort. She couldn't even walk a whole block over the past year. She had chronic daily cough for like 3 years. She had the fun, bright yellow-green mucus that we all know and love as Pseudomonas. And she'd also had a history of MAI. She had intermittent night sweats, probably from the MAI, generalized weakness and fatigue, and she was just very, very coquetic, and I'm going to show you how much she weighed here in a moment. So a lot of her diagnoses that she already had, which was a lot, and so a lot of these are so many things that we see with just our CF patients in the adult world. She had no issues at birth. She had no family history of CF. And then also she had chronic sinus infections in childhood. But then again, a lot of people don't go first to, oh, you have CF, especially when there's no family history. But the other issue is that she's a tobacco abuse patient. She was smoking a half a pack per day for several years. But then when we saw her for the first time, she was down to only 5 cigarettes a day. So she had made progress. Intermittent constipation for your GI, your sinus disease, your migraines. She was told she had diabetes type 2, which was only 6 months prior to coming and seeing us. Some thyroid disease, polycystic ovary disease, infertility. She'd had surgery already. She'd had an ovarian cyst removal, but then she'd also had a hysterectomy in 2015 due to the fact that she was unable to conceive and also the age at which she was at this time. She also had a cholecystectomy, and she'd had several colonoscopies because of all of her GI issues over the years, and she had a local GI physician that was seeing her. So in the records review, they did not send me an image with the loading it. So therefore, just what also prompted this was this chest and abdominal CT. So as you can see that she had those opacities in both lungs. upper lobe more predominant. And so therefore, but her disease had progressed significantly from 2017 to 2020. So, and then the overall appearance in the read was nonspecific, but suggests infectious or inflammatory process. Obviously, she had Pseudomonas in there and MAI previously grown in sputum. Severe hepatic steatosis, and she was seeing local GI for that. Fatty replacement of the pancreas, large volume of stool in the colon, and then she also had a few little renal stones in there. And then a combination of all of these things indicated their read was indicated as systemic process and possibly a syndrome. So this is her first visit to us. She was obviously diagnosed with the genetics themselves, being homozygous for F508. And then even though she had no family history, we still began our treatment. Now, since she was a nurse, she was gung-ho for throw it all at me and give me what I need and in order to feel better. And so therefore, we did initiate her on ETI. We measured her for a vest, given her a handheld device for her airway clearance as well. We asked her to start her Pulmozyme daily since she was very congested and all of the sputum that she was coughing up and this chronic cough. We also gave her a nebulizer whenever she was in clinic in order to go ahead, take that home, get that started. We provided her with the book from the foundation with the new diagnosis of an adult with CF. We put her in contact with an adult CF patient because that's what she had asked us to do. And we have several of our adult patients who are more than willing to talk to other adults about diagnosing late with CF. We did hold on the MAI therapy because, as you know, that they have shown that sometimes whenever we're starting these modulators, you are seeing the MAI actually being resolved. And then we also did some AFB and CF cultures because obviously she was coughing junk up. So her GI issues, she was having chronic abdominal pain and bloating, alternating diarrhea and constipation, the consistent things that you see with pancreatic insufficiency. Her max weight in adulthood had only been 115 pounds, her low 75, and then the day we saw her, she was only 79 pounds with a BMI of 15.6. She said she only ate usually one meal a day because she just had that early satiety and vomiting, more than likely because she had a bunch of stool in there too. So we started some GI treatment. We gave her obviously enzymes. We started her low with that. She started some CF vitamins. She met with a dietitian, and then our dietitian always follows up within a week or two of these new diagnoses just to see, one, how they're doing. Do we need to adjust the dosing of the enzymes and following up with those? We did give her some nutritional samples and supplements to take with her. And then we also enrolled her at the time in the HealthWell grant and the enzyme program. With the diabetes, she had already been on metformin, and her A1C at that time was 7.3. She did have some chronic sinusitis, but that was pretty stable, so she didn't want to add any other therapies for that. For her tobacco abuse, she was trying nicotine patches out, but really wasn't feeling like they were doing much good. But then she also mentioned that she really didn't want to quit smoking either at the time. So she had, we saw her in 3 months because our social worker saw her at the first visit, and then she also follows up with her. So there is interim follow-up, but just in person in 3 months. She had been hospitalized, unfortunately, in May with liver issues, ascites issues, constipation, diabetes, and anemia. Many of those things were addressed. The ascites was resolved by the time she came back to us. Constipation, they did start a good clean out with her to get that resolved also. The diabetes, they kept with her regular meds, and then anemia, they gave her a blood transfusion at that time. So once we started the enzymes in this 3-month visit follow-up, her cough had mostly resolved. It was non-existent now. She felt great. She was taking her ETI with her DNase and her albuterol. She was using her Aerobica, not really using the vest too much that we had measured and gotten for her. Still having some constipation, so therefore she's still on her enzymes, she's still on Linzess, she's also taking some lactulose as well. Blood sugars are under much better control, and all of her readings are below 200, and now her A1C has dropped to 6.5. Still using tobacco. She said intermittently, but when you really push her, she's more, I'm still doing 5 cigarettes a day. And then her ascites was much better controlled after she actually had been in the hospital as well. So I just wanted to kind of show this from a registry standpoint, just so you can see the market increase in just from March to September when we saw her at her 3rd visit only. So as you can see, her functions, FEV1 alone, went from 1.18 liters to 2.64 liters. So she's going from 45% up to 102% just by starting on ETI and doing a couple of therapies. And her weight was much improved as well. So in those interim years, like I said, she was on and off various medications per herself, deciding what she wanted to take and what she did not want to take. So therefore, she decided that she didn't want to take Pulmozyme all the time or the albuterol, so she switched that to as needed for herself. And then for her pancreas, well, she was feeling better there, so therefore we might take them, we might not. And her liver issues were getting better, and then she was having some mental health issues with anxiety and depression as well. But her primary care was taking care of that with some medications. And obviously still smoking, no desire to quit yet. So where is she now? So her diagnosis then and her diagnoses now, a lot of them are the same, because a lot of these are chronic illnesses. We're not going to change, but hopefully we've improved some of the signs and symptoms of what she's been experiencing. So obviously now she's got cystic fibrosis diagnosed rather than just chronic bronchitis. The sinusitis continues. NTM disease, she's not coughing anything up anymore, so therefore we're just kind of waiting for her to expectorate so we could actually recheck that as well. Pancreatic insufficiency, much better now that she's on enzymes. Well, taking them when she feels like it. Some GERD issues, secondary biliary cirrhosis from the CF. Still some chronic constipation, but she had gone up to now 8 cigarettes a day from 5. Her anxiety, and then the CFRD. So I just wanted to show you a picture of her chest x-ray from May of 2021, which was right after we had diagnosed her, and then June of 2025 this year. So you can see there's improvement in there as far as with the mucus plugging and the bronchiectasis that's there too, pretty much is what you'll see in the 2025. Yes, even her constipation, you see more air in that gut. It's great. Although she still has problems with it. So here's over time. So from 2021, just because we only have the last 10 on our results whenever we do the PFTs. But you can see that, she's so much better from a 1.1 previously whenever we first saw her. And she's feeling a heck of a lot better too. So improvement over time, so this is from the registry. So this just gives you a better idea where her BMI, we got her to 100%. And I think the little downward trend that you're seeing in 24 and 25 is also because she's still only taking her enzymes when she feels like it. So we're still having a discussion about that. And then obviously her FEV1 and FEC have steadied out, and she's pretty stable. So her most recent visit, when I saw her at the 1st of September, which is 4.5 years after her diagnoses. So her weight when we first saw her was a BMI of 15. And then, so now today she is at a BMI of 22.4. So she has normalized, at least for September. And then her FEV1, 1.18 when we first saw her. Now she's 2.30, 98% predicted. So she obviously is on minimal scheduled medications, but she does take her ETI with no missed doses. All other pulmonary meds, they're just as she needs them. Her A1C has dropped to 5.6, So therefore, she is off the metformin that she was on before. Her constipation is well controlled, although she does not like water. And so therefore, we're still working on that whole soda intake because she does drink a lot of it. Smoking cessation. Initially, she planned, because of her husband was going to have to pay extra on his insurance for the new year. So he's quitting and she's quitting. Initially, they told me at this visit, we're going to start on October 1st. That's our goal. I talked to her a couple days ago. Halloween is their start date now. So they're going to get it. And then, obviously, the last chest films, the nodularity improved. And then we did send a new AFB culture when I saw her in September, and it has come back negative since then, as of 2 days ago, actually. Her anxiety medications, she's been trying to reduce those with her primary care over time. And when I talked to her a couple days ago, she said that she's actually off of them. So that was part of the other reason why she didn't want to start smoking cessation at the beginning of October, because she was trying to wean off those anxiety medications as well. So currently, she's not working full-time as an RN anymore, but she is working part-time. So I wanted to share a few words from this patient, because at first she was going to actually join us, but then her anxiety got the best of her. And so therefore I just asked her a few questions to share with the group here. So I asked her what her biggest change since the diagnosis for herself was, and she says, not coughing every minute of the day, not being covered by salt after sweating. You can tell the light-hearted side of the story of what Jim says, joking, of course, I can't find you in the stores anymore, because he used to follow the cough through the store, because she's a very short stature, so therefore he couldn't see her over the racks. And then I asked her about what does she enjoy now that she could not do before we diagnosed her. And she said, because of sick she was, she thought her life was going to be over soon. She had stopped traveling and even really stopped enjoying life at all. All they did was stay home because she never felt well at all. She says she feels great these days. They're back to traveling. They're enjoying time with friends and family, which was usually cut short because she needed to go home and rest. And then also the shortness of breath, the stomach issues, those are all better. She said after her CF diagnosis, it was only a matter of days after getting meds that the cough stopped. I was breathing better than I have since I can ever remember. Then she said she really wanted me to put this in, and she said that she just wanted you to know that our team celebrated her birthday at one of her appointments after getting so much better and feeling so much better, and so therefore she's just said it made her feel special because she wasn't even for certain she was going to make it to that birthday. So I asked her for words for the CF community in general, for providers and everything else. What would she suggest? And this is what she had said. She said, strong support was the key to my survival before the diagnosis. She goes, her husband, Jim, was bathing her, carrying her to bed, literally doing everything. She would absolutely brag about our team. God love her. You are literally helped us with everything from eating and digestion, breathing, mental health, understanding medications, insurance, and other assistance available. They were so blinded when her husband's insurance wouldn't cover her medications and such. So it was this huge process to finally have a diagnosis, then be hit with the struggles of finding insurance that covered what we needed, and then also getting the help to pay for the insurance or the CF meds. Again, she wasn't working at that time, and she didn't qualify for Medicaid or Medicare due to the fact of how much her husband makes. So it was a huge battle that, again, her husband took on due to her being very overwhelmed and not understanding insurance stuff. So I asked her also some suggestions for others diagnosed later in life if she had anything to share with them. She said, stay positive. Teach others about the disease so they understand what a day in life of the CF patient is like. She said, we had no idea what CF really was or what we were in for, but we are aware now, and they have so many tools from the medical team and the CF Foundation. The foundation and our team have had our backs 100%. Watch the movie 5 Feet Apart. It really opened my eyes to what CF is for others and what I learned. I was so lucky to be alive being diagnosed at the age of 40. It really caused so many other problems, but those have also been fixed with meds or major life changes. So the things that we kind of consider whenever we're diagnosing these adult patients is to basically, we're starting with the pulmonary if that is their main reason for coming in. And usually you can get them on a few meds, usually albuterol, usually a modulator now, and then perhaps either hypertonic pulmozyme, one of them that's going to help those secretions that they're having. Some airway clearance, what will they do? And that's what you got to bargain with them. They already have habits. Then they're going to have to break some, and it's hard, it's time consuming, and then they're going to have to develop new habits in order to treat themselves. So sometimes they'll do exercise and, or, whether it be one of the devices. GI, we're going to give them enzymes if they need them at that first visit too, and do some constipation management and some reflux management also. There's obviously continued issues, so those follow-up visits, we're also addressing many other things. Their mental health, their sinus disease, their bone health, their CFRD, reproduction, liver, and sometimes some rheumatology issues. So it's always continuing on what you're addressing, but you're just having to go slow because, like I said, they've already developed habits. You're asking them to take on more habits in their care. So for future visits, we just continue to work on the new and the old issues. We support the patients where they are in understanding their new diagnoses and what they have to do. We support the patients in how quickly they can make the changes that are needed. Some are a little slower, some are a little faster. Congratulate them on improvements no matter how small they are. Habits are hard to break. And then always ask about as far as how they feel about it, what is their mood, what are their concerns about everything, and how can we help. These are just some references and then some information. So, and now she's heavily involved in CF fundraising too, which is great. So.
Any questions for Jana?
I was wondering, for any ages, we have experience with patients playing Dr. Google and calling, I have all these symptoms, I think I have CF. How do y'all handle those patients? Do you have primary care do some of the workup? Do you do any virtual visits, or kind of how do you handle similar situations like that?
So it depends on what those signs and symptoms are that they're telling me they're having, for one. But usually, yes, I always have them get a sweat test. And if it's the primary care physician who is sending them over, then I usually talk to the primary care office and tell them exactly how to order one. And I'll also tell them where the closest lab is for them to get that done. And then others, sometimes it's GI, especially some of the folks who have pancreatitis chronic. So therefore, over the years, I've actually gotten to finally do sweat chloride testing before they actually send them over. So that's helpful. But usually, yes, I will always have a sweat test prior to. And what's nice is that with our sweat lab, if it's either intermediate or it's positive, I get a notification immediately, along with them notifying whoever ordered it. But that's how I'll do it.
I have a question. So from an infection control perspective, she's a nurse. So where does she work? And does her diagnosis affect her job?
Well, she's just working PRN now, so mostly it was home care that she's doing now. Before, she actually worked at a private hospital, which is a very small population. And so this was before her diagnoses. And then after she diagnosed, she then obviously stopped being a nurse for a little while, took a break.
And then one other question. Did your team ever consider having her on the advisory board, parent-patient advisory board?
We haven't yet, but because we've had patients rotating on the advisory board. But yeah, I'm sure she would be gung-ho about it. Yeah, she'd love it.
It's a nice segue into what I wanted to ask. I just wanted to say first, thank you to all of you. Your presentations were so wonderful. I really appreciated all the ideas that you all gave on PFACs. Ours is just getting going after a break from COVID, and to just hear the different ways that your PFACs are impacting care and offering resources and support to your patients and clinics was really motivating. With regards to the adult late diagnosis, I think you referenced the patient's husband a little bit, but I was just curious if you had any best practices or tips from your experience in engaging family support system in ways that maybe that has help patients cope or process the information that you're giving them?
I know that our social worker, whenever she meets with them, and she will dive into that aspect of it, of how much support do you have. Some patients have, yes, their parents, their siblings, they're around a lot. Others are here by themselves along with, their husband or spouse or whoever. So, we just try to see what resources they actually have. And then, we try to, reach out to other patients to talk about things too, which I think a lot of the adults feel that is very helpful, because you were diagnosed at this age, we're very similar. And so therefore, how did you work with this and everything else? We also have a CF psychologist that works with us too. And so sometimes we can put him in contact with her as well. She only does virtual visits for now, but she does a lot of coping mechanisms with patients. And so therefore she's been very helpful as well.
Are there any general questions from the panel that we can help to answer about the presentations and early and late diagnoses? Oh, sorry, we just figured out how to use this app. Okay. One of the questions was, do you notice a prevalence of developmental delay associated with a newborn CF diagnosis? Do you feel as though it would be beneficial to have PT/OT evaluate early on to prevent delays?
Do you turn this on?
It's probably on.
Sorry, it's on. So yeah, I can answer this one. So we do have a physical therapist in our clinic who does come evaluate babies and make sure that they're meeting those developmental milestones. We do, I wouldn't say overall developmental delays, but more so feeding, oral aversions, sometimes speech. And so I think it's important to recognize those early and then refer out to appropriate therapies as needed. Did you add anything to that?
Okay, and then a question from Justin. He says, for smoking cessation, was Wellbutrin or bupropion ever brought up to talk with the PCP as both an antidepressant and for smoking cessation? This one's for Jana.
She had tried Wellbutrin before, and part of it was also she just had no desire to quit either. She was going to keep that 3 to 5 cigarettes a day. And even when I talked to her in September, because her husband is obviously quitting, and that's his goal, but when I asked her, are you doing the same? And the look on her face was not promising. And so, she had tried some Wellbutrin in the past, and part of it was she didn't want to quit either. So that was part of it. But she was already on some antidepressants or anti-anxiety medicines through her primary care already. I think she was on Lexapro.
And then this is from Melissa. She wants to know, can you please provide further details on the nurse follow-up post-appointment, the call post-appointment?
Yes, happy to. I'd be happy to email the template too if anyone is interested. But we check in, see how the baby is doing with feeds. We check on enzymes. We do get an updated weight. So if the weight has increased significantly since the last clinic visit, we can adjust the enzyme dose rather than waiting till the next clinic. We see how they're doing with salt. The nurse can offer any tips and tricks if the parent says the baby is struggling with those things. We also touch on resources, so just reminders about cff.org, mentorship. They tell them about our CF in Utah Facebook page, just kind of letting them know about support and resources. And then they also review key infection control topics because Max has probably had the most experience with this, but I swear we always go over like big infection control things, mainly hot tubs, humidifiers, hot springs, those kinds of things. And for some reason, Max gets the teenagers that are like, oh, I'm going hot tubbing. So we've realized that we need some reinforcement, re-education to some of those points. And we know that that first visit is very overwhelming. We're very clear to tell the families we don't expect you to remember all of this. We will check in, write down questions, and really just gives them an opportunity to reiterate, check on the baby's clinical status, see how they're doing, answer any questions, and then also make sure that they know how to get a hold of us. It's us reaching out to them. And then we can feel confident from there. You guys know how to reach out to us. Do you have any questions? We also make sure they have all the medications and supplies and feeds and everything that they need. And then also that they have follow-up appointments scheduled.
I have another question from the app. This is from Carla. With the time gap between our state initiating newborn screen and the relatively new guidelines for following babies with CRMS, we know that there are kids whose parents were told they were fine and no follow-up was scheduled. Now we know we should have been following them. What are centers doing with this population? Are you bringing them in for repeat sweat testing and a visit? If yes, who is contacting them? How are you explaining why they're being called back after potentially several years?
I would say before, so before those guidelines, when we went through and re-looked at all of our patients, we had actually found one particular patient who was told at the time of their sweat that they did not need to follow, but by even the previous guideline, we should have been following them annually. And at that time, the patient was then 17, I believe. So we did reach out to that PCP to get a gauge of where that patient was health-wise, and gave them the information about, hey, if you're seeing any of these things, they should really re-engage with us. But they had been healthy to that point with no sort of indicators for concern. So we sort of just left it with the PCP of watch out for these things, let us know. And I think we've done that several times when patients have disengaged with care. We've sent the PCPs letters saying this is times they should come back into us. And if patients were initially engaged with us, we'll send it directly to the patient as well. But it is definitely a hard thing to sort of cold call somebody after a decade and say, hey, you should be seeing a CF doctor.
Any other questions? Okay. Thank you all for coming.